morning, everyone. Thank you for being here this early on a Saturday morning. Typically, if I'm in Vegas and I'm up this time on a Saturday, it's because I haven't gone to bed yet. But that's not the case today. So thanks for coming to our breakfast symposium, Every Heart Covered. My name is Amar Dhanantwari. For the medical affairs at Canon Medical Systems. And I'm going to start off by giving you a little bit of an introduction to the most recent advance in deep learning reconstruction. That will be followed by Dr. Chen, who will show us some of the clinical examples and the clinical benefits of some of the technologies. So, if we look at innovations in reconstruction technology in recent years, roughly the past decade, on the top of this slide, you can see we had the hybrid iterative reconstructions such as 8 or 3D. Then we went on to the full model-based iterative reconstructions such as FIRST. And then more recently, we've gotten into deep learning reconstruction being ACE and deep learning Spectral. As you can see from the names, these last two technologies were enabled by deep learning. So the question is, first question would be, well, what is deep learning? So deep learning is the most sophisticated form of artificial intelligence. And it's based on these deep convolution neural networks where the models are trained with data. So you present to the model the inputs, what your starting point, and you also present to it what you expect as the output or your targets. The model then learns how to translate those inputs to outputs, and all of the learning happens based on the data you provide. Why would you want to use a deep learning approach? With a traditional approach, let's take the example of facial recognition. If you're looking at programming an algorithm to recognize a person, you might look at geometric measurements, geometric features, such as the shape of the face, distance between the eyes, things like that. And it's typically things we can contemplate as humans. And the accuracy of these types of algorithms are about 60%. With a deep learning method, what you would do is you present pictures of the person that you want to recognize, and you say, this is who the person is, model learns, and it looks at the data in ways that we may not be able to contemplate. And they hit a success rate of greater than 97% in the case of tasks such as facial recognition. In CT reconstruction, we do basically the same thing. We presented the input, lower quality, low dose, high noise data, and we also say the target is these high quality images we want to achieve. And we let the model learn how to get from that input data, which may be noisy, to the output data. The model learns the optics of the system, the models of the system, the anatomical models, all of that is inherently learned by the model. And at the end of it, you have a reconstruction algorithm that can translate your high noisy images into low noise reconstructed images. So that is the case with ACE reconstruction, where you can see you can get clear, sharp images, low noise, great spatial resolution, and great low contrast detectability. Similarly, we can take advantage of deep learning for Spectral. Our platform is based on a KV switching method. And with KV switching, you end up with two data sets, an interleaved data set, which is not complete in high energy or low energy. For this problem, we trained a neural network to complete that data set. So basically, to take the incomplete sinograms and produce complete sinograms. From that, you can decompose these data sets and produce spectral images. One of the challenges with spectral images is that resulting images tend to be noisy. So here you can see we have a second deep learning network to basically denoise those images. So there are two neural networks operating in our deep learning Spectral. But with these two networks, we can have excellent image quality, which enables visualization, characterization of materials, and quantification from a spectral CT. So with our spectral CT today, you can do 1-beat spectral cardiac at 0.27 rotation, so full volume acquisition, 16 centimeters. On the other side of the coin, let's look at the detector technology progression. Canon has long had one of the smallest detectors in the industry, 0.5 millimeter detectors. And this has been through all of our generations of scanner, from the 4 rows to the 80 rows, and then eventually the wide area detector with 320 rows. More recently, we developed an ultra-high resolution scanner. This scanner has 0.25 millimeter detectors. So the detectors are quarter the size of our standard detector. But this scanner operates at 80 rows. So it would seem that the natural next step in the progression is to bring this capabilities of this ultra-high resolution scanner to the wide area detector. And we thought deep learning might be a good way to do it. But for deep learning, obviously we need the data and we need the models. So if you look at the Aquilion Precision, it has a number of operating modes. One is the super high resolution mode, where the detector is at 0.25 by 0.25. But you can also operate the scanner in the normal resolution mode of 0.5 by 0.5. So it also turns out, from a given scan, you can produce a reconstruction at super high resolution, and for the same scan, you can produce images at the normal resolution. So with these two sets of data, we have what we need to train this neural network, which is present normal resolution image and ask it to produce for us high resolution images. Is this technically feasible? Well, it has been proven in the past in the fields of, for example, satellite imagery, digital photography, that deep learning can improve spatial resolution. So knowing that it is technically feasible, we have the data, we brought these two together, and that brought us PEAK, which is Precision Clear IQ Engine. And that gives us super high resolution images based on deep learning on the wide area detector. So this slide shows us how the whole process works. So you can see in the panel that says training, we have data acquired on the precision scanner, reconstructed in high resolution mode, super high resolution mode, and also simulated at normal resolution mode. That's our training data, with the normal resolution being our input and the high resolution being our target. Once our network is trained with that data, we can deploy it wherever we want. So that is what is then deployed on the wide area detector, and that is what gives us PEAK reconstruction. So with full 16 centimeter of coverage, we can now have high resolution images. The improvement in resolution is measurable, as you can see from this MTF curve across the board. The MTF is double that of our hybrid iterative reconstruction methods, and that's in XY, but also in Z. So you can see here the bar patterns, the improvement in resolution from PEAK in the Z direction, but you can also see it in that clinical image where those tiny vessels are tracked much better in this volume image. Taking a closer look, here's another case. You can see the improvement in the image quality and the visualization of those small vessels and the detection of that small vessel as pointed by those two arrows. It's another example with PEAK compared to 8 or 3D. You can see, first of all, you can see the walls of the vessel much more clearly. You can see the reduction in blooming, and you can see your ability to track that lumen in the presence of that stenosis. So in a nutshell, that is PEAK, where Canon is pushing the frontier of technology. We were, for a long time, working on volume coverage, wide area detector. In parallel, we were working on high spatial resolution, and with PEAK, we were able to bring those two together with deep learning to have super high resolution, wide area CT. So with that, I'll turn it over to Dr. Chen. Dr. Chen is the Director of Cardiovascular CT at the National Institutes of Health and in Bethesda, Maryland. Dr. Chen has been a long-time partner of Canon from the very early days of the wide area detector. So Dr. Chen is going to show us a little bit as to what it means to have this technology clinically.
Good morning, everybody, and thanks for the introduction, Amar. All right, so in about the next 20 minutes, I will talk about Aquilion 1 technology. In this audience, I don't think I need to go over this much in detail, but the recent acute chest pain guidelines published last year that gave cardiac CT a 1A a 1A indication was further strengthens the evidence on the power of cardiac CT. And it has mnemonic chest pains, but the one thing to remember is to use clinical pathways, the P, and also for eyes to identify patients most likely to benefit from imaging. And this is where Aquilion 1 technology can really help your patients. So if we look at some of the algorithms, so this is for a patient with no known coronary artery disease. If they have had prior testing, if they're intermediate risk with no known disease, and have had, the question is whether they had prior testing. If they've had no prior testing, you can have a choice. You can have a choice to do a functional test or to go ahead and proceed with the cardiac CT. But what the guidelines, this is where it has a 1A indication, and it says it's basically useful to exclude the presence of obstructive coronary disease. Now, how about if you have someone who has known coronary disease? So if you just walk through the pathway here, if they have known non-obstructive disease, less than 50% stenosis, you have an option to use cardiac CT, or you can use a functional test and do stress testing. However, the guidelines do specify it in it that test choice should be guided by local availability and expertise. And what I'm going to show you in the next couple of minutes is how the technology with Aquilion 1 really allows you to scan almost any patient. Okay. And again, the guidelines, are great. They, kind of walk you through patient populations that would favor cardiac CT or favor stress imaging. But again, it's about availability and local expertise. So as Amar mentioned, we've been a longtime partner with Canon Medical. We had the original Aquilion 1, the first generation Aquilion 1 installed in 2009. And about every 3 or 4 years, we've been upgrading to the newest technology available. We went with faster gantry rotation with the Vision platform. We went with an improved resolution with the Genesis platform. And now we have a spectral capability with the Prism. And on the research interest, we've had what Amar just went over is a super resolution deep learning reconstruction that we've been evaluating for the last year. So if you look at Aquilion 1 technology, we have whole heart coverage with 320 detector rows and 0.5 millimeter detector thickness. So with the schematic, we image the heart within 1 heartbeat. Very simple scan to do. If we need to, we can get functional information and not have any stair step or misalignment artifacts. If you don't have a wide area detector, what does the images look like? Well, this is what it looks like. You may get stair step artifacts, you can have banding, you can have misalignment if the patient breathes between different scans. But with Aquilion 1, you have complete organ coverage. We scan within 1 heartbeat. We have temporal uniformity where there is no contrast gradation. There are no stair step artifacts. And this makes my life easier interpreting these images. And if you're better able to evaluate the anatomy, you can translate to evaluations of physiology if you do myocardial perfusion imaging, or if you do CT-FFR, or do some of the newer plaque analyses, AI plaque analyses. So this is going to be a nightmare case. This is a patient who has a calcium score of over 4,000. Some people, if they do a calcium score, if the calcium score is more than 1,000, they may stop. In my practice, I'm not scared of calcium. Every patient, if it's clinically ordered, we will proceed with a contrast evaluation. And here's an example. Very high calcium score, but the images are completely interpretable. And I'll just note that this was a sub-millisievert scan as well. Aquilion 1 has a gantry rotation time of 275 milliseconds. And what does that allow you to do? Well, everyone knows that technologists will coach the patient, let them know that when the contrast comes in, it'll be warm. They feel like they almost peed in their pants, but they didn't. So we had a young patient, even though the coaching, the contrast came in, and she started screaming on the table. And I was actually in the control room doing this, and I was like, oh no, this is gonna be bad news for me. So here on the image, you can see that there's, oops, sorry. Yeah, and you can see the lung parenchyma is not crisp. However, the heart rate of 94, the images were completely interpretable, despite a heart rate of 94 that we were not anticipating. Aquilion 1 also has arrhythmia detection. And basically, the scanner will detect whether or not there's a premature beat. And if there is a premature beat, it will go ahead and, my animation's not playing, it will go ahead and expose at the next normal RR interval. So what does that look like clinically? So here's a patient with atrial fibrillation, which again is a very challenging to image. Patient widely variable RR interval. With the first beat was shorter RR. The scanner stopped the acquisition to minimize radiation, and with the next beat, it automatically opened up the exposure window, and with this, we're able to get a completely diagnostic scan. Here's another patient, even faster heart rate 124. With multi-segment reconstruction, we're able to get completely evaluable images. The system has automatic phase selection, where the scanner will automatically determine the best phase and find the phase with the least amount of cardiac motion. So some people, despite a low heart rate, this is a patient with a heart rate less than 60, heart rate 59. So despite the heart rate being low, the scanner will go ahead and find the best phase. Typically, the best phase is 75%, but in this case, it was slightly different, it was 76%. And the images, as you know, are a little bit crisper if there's no coronary motion. Aquilion 1 also has cardiac SEMAR, which is metal artifact reduction technology. So all CT systems have metal reduction removal for large orthopedic devices like hips. However, on Aquilion 1, we have the same technology that's able to remove metal from pacemakers and surgical clips. So here's an example. Patient with an ICD, and most frequently, the right atrial lead can obscure the right coronary artery, as in this case. We can apply cardiac SEMAR, and now we can now visualize that proximal right coronary artery. Now I'm going back to the guidelines, the acute chest pain guidelines, and the chest pain guidelines for patients with prior bypass surgery has a class 1 indication. So here's a patient with prior bypass. Here's a Lima graft. Again, you get these surgical clips, Now, if we go ahead and apply SEMAR to that, we're now able to see the lumen of the left anterior descent of the lemma graft. I'll just blow that up for you. So this is the conventional image, and that's what SEMAR. So this is available on Aquilion 1. Now there's also, as Amar just mentioned, there's artificial intelligence deep learning. There's different flavors of that. So the one flavor of it is ACE. And with this level of artificial intelligence, we're able to reduce the amount of image noise. So this was available up to about last month. That was a clinical standard, but now we have the super resolution deep learning reconstruction. I'll show you a couple images of that in a moment. But with conventional deep learning reconstruction, we're able to really suppress the image noise. And here's a patient, BMI 55. They're huge. They're huge. 275 pounds, 5'5", large amount of attenuation across the chest, but we're able to get a completely diagnostic image. And just to remind you again, so going back to the guidelines again, the recent guidelines, if the patient has an inconclusive prior functional test, you can go ahead and do a coronary CT in two different ways, right? So if they have prior inconclusive, or if they had no prior testing and they went through the arm to have a functional test, and if it's inconclusive, then they can have a cardiac CT. All right, so the real exciting thing that I want to share with you is some of our experience with the super resolution deep learning reconstruction. And again, just real briefly, the way that this was trained is that the low resolution images were trained on the precision, which had ultra high resolution as 0.25 millimeter detectors. And that developed the convolutional neural net that's then deployed onto the system. And to give you an idea of what this looks like, so on the left is, this is a stent case, is a conventional image. In the middle is the ultra high resolution image. And this image was trained on the ultra high resolution precision 0.25 millimeter images. So we're able to get back the resolution from these lower resolution images. So going back to the guidelines again, what do these recent guidelines say for stent evaluation? Well, it's a 2A indication to evaluate stents that are equal to or greater than 3 millimeters in diameter. So this is what it looks like. So on the left is our clinical standard, which is ACE, and on the right, with super resolution deep learning, we're able now to better visualize the stent. We're able to see the individual stent struts. So we did a small study to evaluate the image quality using this super resolution deep learning, and our objective was to see what the image quality was compared to the standard resolution cardiac CT. So we had institutional IRB approval. We looked at 52 consecutive patients who were imaged on an Aquilion 1 Prism or Genesis. And each scan was reconstructed. And we had experts look at the images and grade on the 5-point scale, with 5 being the best, at spatial resolution, noise, diagnostic confidence, and overall image quality. We also looked at SNR. So on this graph, the kind of the green on the left hand is the standard recon. On the right side is the super resolution deep learning reconstruction. And in every image category, whether it's image quality, image noise, spatial resolution, or diagnostic confidence, there's a significant improvement in the image quality. So let me give you a couple examples. So here, on the left, for all these images, the left is a standard image. On the right is the new super resolution image. The images are a lot sharper. What I say is it's like, if you wear glasses, I don't know if you remember getting your first pair of glasses, but the eye doctor, you get them, you put them on, and everything's so clear. This is what it's like. It's like wearing glasses for the first time. You're starting to see things that you did not see before. This is a figure just to show you how the amount of image noise. So if, we measure the image noise in the left atrium. The amount of noise is, if you can't read it, it's standard deviation is 30. Here it's 20. But visually, you can see that the images are crisper and less noise, and subsequently there's a higher signal noise as well. Now, if you look at a fine structure such as the aortic valve, again, left side is standard, right side is the new super resolution reconstruction. Here's another stent case. On the left, standard reconstruction, on the right, super resolution. And now we're able to consistently evaluate the stents, see the stent struts, look for in-stent restenosis, and stents are some of the most challenging cases. Our diagnostic confidence is also improved. Everyone in this room has seen scans like this. Is there stenosis here? It's a little bit blurry here. But if you apply the super resolution imaging, this is what you see. There definitely is a plaque. We can better visualize and quantify plaque now. Again, another quick example. LED stent, better able to visualize it. I mentioned about plaque quantification. So again, left is standard recon, right is super resolution. I'll just mag that up for you. So we're better able to visualize these areas of calcification, the blooming artifacts minimized, and we're better able to delineate the areas of non-calcified plaque. I'll just blow that up for you. So in conclusion, with peak or super resolution images, it has improved spatial resolution, has improved noise characteristics, we have improved diagnostic confidence, and it's superior to standard imaging that we have now. And what's also important to realize is that every time there's a new image reconstruction, you always worry about artifacts. And in our experience, we have not seen any artifacts with this new image reconstruction method. So what happens if you put all these technologies I went over together? Well, you can do very low radiation studies. With the original vision, almost 10 years ago, my group, we demonstrated we could do sub-millisievert exams consistently. Another group, more recently, has also demonstrated that. Just a quick example, this is a normal-sized patient, 5'3", 121 pounds, BMI 21, that's an average-sized person. Do ultra-low doses, 0.17 millisieverts, completely diagnostic. But when you do these low radiation dose exams, it's very important to not miss disease. So, here's an example. Here's a patient who's got a very significant left circumflex stenosis and has some non-obstructive disease in left anterior descending. This is a normal-sized person. This patient's actually almost obese, right? It's a BMI 29, normal-sized. 5'5", 150 pounds. This is a normal-sized, unfortunately, U.S. population. This exam's at less than millisievert, 0.9. But here's your corresponding invasive angiogram. And it's, we got spot on. And this is what you can get with the Aquilion 1 technology. Now, in the Washington, D.C. area, I'm known to have a high-end scanner, and I get sent really tough cases. So this is a patient at a 7-centimeter aortic root, needs surgical replacement. They did invasive angiography, and the root was so dilated they couldn't engage the coronaries. So at the outside center, they went ahead and did a cardiac CT. They tried giving beta blockers, the heart rate, the best heart rate they can get was 78, but there was motion artifact. All right, so big, huge aortic root, coronary motion artifact in the right coronary artery, and some in the left there. So they referred this patient to me, and I said, okay, I can, I've got great technology, I'll go ahead and scan this patient. We weren't able to get the heart rate down any lower. This is a heart rate of 80. But, given all the technology that I just showed you, we were able to get a completely diagnostic scan on this patient. So just going back to the guidelines again, there are ideal patients for cardiac CT in this audience. I don't need to go over this. And in the guidelines, they also mention, choose the right test. They go through who are the best tests for stress nuclear, for stress echo, for stress CMR, and for cardiac CT. But in conclusion, the Aquilion 1 really can cover every heart, and it's because it has this amalgam of all this great technology. It has a 16-centimeter detector and image the entire heart. We image, most times, within 1 heartbeat. Radiation dose is less than a millisievert. It's got metal artifact reduction for those tougher cases, bypass cases, to remove any sort of blooming artifact that might obscure the grafts. It can deal with arrhythmias. It's a scan and forget. The technology does not need to do anything. It tolerates very high heart rates. And we now have super resolution deep learning reconstruction, which really enhances the image quality, makes the scans easier to read, especially in tough cases with stents or dense calcification. So thank you for your attention, and I'm happy to answer any questions that you might have.